Welcome back to The Great Adventure, Pediatric Pulmonary Physiology. This is the 20th presentation in a series of 30. Today we're dealing with control of breathing, part 1. This is The Great Adventure, Pediatric Pulmonary Physiology. And you can see we're moving along. And we want to approach this with the enthusiasm of a child in a candy shop. So we've talked about the respiratory balance. The last 3 times we focused on ventilatory muscle function, but don't forget that central drive must also be adequate to overcome the respiratory load. And that's what we're going to focus on for today's session and the next one following that. So we're going to talk about voluntary and automatic control of breathing, central chemoreceptors, peripheral chemoreceptors, and pulmonary reflexes. So the question comes up, what is central drive? Your brain tells you how deep to breathe and how frequently to breathe. Your brain can measure oxygen and CO2 in your blood and increase your breathing when oxygen falls and or CO2 increases. Ordinarily, your brain may need to increase breathing during stress, such as exercise and pneumonia or other lung diseases. So this depicts the brain and respiratory control areas. In the motor strip of the brain is housed the so-called behavioral or voluntary control of ventilation. Presumably, I could ask any of you in the audience to take a deep breath or to hold your breath. If any of you cannot do that, we'd love to study you here at Children's. But my ability to do that and also to make fine bursts of expiration means that I can make words and you have to listen to this presentation. This is all voluntary. I can think about that. On the other hand, you don't think about breathing all the time, and so there is also an automatic, or sometimes called metabolic, control of ventilation, anatomically housed in the brainstem. And this type of breathing is automatically controlled, and it's basically closely regulated to blood gases. There are also a number of other reflexes from peripheral chemoreceptor, chest wall, lungs, body motion. So voluntary or behavioral control, anatomically housed in the cerebral cortex, responsible for voluntary breathing, speech, laughing, etc., not regulated by blood gases. Automatic control or metabolic control, anatomically housed in the brainstem, tightly regulated to blood gases, and there's also input from many reflexes. Let's start by talking about central chemoreceptors. So central chemoreceptors directly stimulate the ventilatory controller, which results in increases in ventilation minute to minute. The central chemoreceptors are located in the medulla in the brainstem, and it responds to hydrogen ion change in the cerebral spinal fluid. Now remember, there is a blood-brain barrier which does not allow ions to cross. However, CO2 can diffuse into the CSF from blood, and this causes an increase in hydrogen ion concentration, which stimulates the chemoreceptors. Remember that water plus CO2 is carbonic acid, which then breaks into hydrogen ion concentration plus bicarb, usually bound to sodium. These respond to acute changes in CO2, PCO2, and are responsible for fine-tuning of breathing minute to minute. That is, just a small increase in CO2 will be detected and you will increase your breathing to try and bring that back down. Tightly regulated, responsible for acute changes, and this is responsible for the fine-tuning of breathing minute to minute. So we can measure the ventilatory response to hypercapnia if we plot minute ventilation against alveolar or arterial CO2. And this can be done in a rebreathing fashion. And so you can see that once CO2 starts to increase here, it's very tightly regulated. The R value for the linear relationship is high, and you can see this is a pretty strict relationship. Minute ventilation increases linearly as CO2 increases. The slope of this line determines the response. So if the slope is this direction, that's a decreased ventilatory response. If it's this direction, it's an increased ventilatory response. Turns out if we plot the tidal volume response or respiratory rate response separately, they also each increase. Tidal volume is much tighter than respiratory rate, but you can see that both increase as CO2 increases. This is the theoretical so-called Kurt von Euler response, that when you do a hypercapnic ventilatory response, especially a rebreathing one, initially what happens is the tidal volume increases and inspiratory time remains stable. Then when you get to a certain point, inspiratory time falls, meaning more rapid breathing, and the tidal volume increases further. This is the actual value from a female normal hypercapnic rebreathing response. This is a male hypercapnic rebreathing response. Again, minute ventilation against CO2. Not quite as robust, although the R value is the same as in the female. And again, tidal volume increases more readily. Respiratory rate in this example doesn't seem to change much. This is a rebreathing hypercapnic ventilatory response from a child with a rare genetic disorder called congenital central hypoventilation syndrome. These children have complete absence of a ventilatory response to CO2, and you can see that this is a shotgun blast. There is absolutely no relationship of minute ventilation to PCO2. Again, looking at tidal volume, no change. Respiratory rate, again, no significant change in this disorder. So this is pathologic. And this is the VTTI plot, again, nowhere near what it's supposed to be. Now, there is a measure called the mean inspiratory flow rate. Basically, if minute ventilation is equal to tidal volume times frequency, frequency actually equals 1 over T tote. T tote is the total time of the respiratory cycle. So if you're breathing 20 times a minute, T tote would be 3 seconds. Okay? So we can reconfigure this equation, VT times 1 over T tote, and then we can multiply top and bottom by Ti. That does not change the equation. And if we reconfigure Vt over Ti, Ti over T tote, okay? Vt over Ti is what's called the mean inspiratory flow rate. And it's actually the most stable measure of central respiratory drive. So this basically is how fast you get that, not just how fast, but with what speed and force you get that tidal volume in. TIT tote, we talked about, is the duty cycle. This measures the time of diaphragm contraction. It's not really a measure of central drive. But by reformatting the equation this way, we can look at mean inspiratory flow rate, which is perhaps the best way to measure this. So here is in the normal female, if we plot VTTI versus CO2, a very tight linear relationship. TITO doesn't really have much change because it's not a measure of ventilatory control. In the male, same thing. Very tight VTTI or mean inspiratory flow rate. TIT tote, again, not a measure of ventilatory control, does not change. Now look at this example in a child with congenital central hypoventilation syndrome. So when we just plotted minute ventilation over PCO2, we had a shotgun blast. But when we plot VT over TI, that is the mean inspiratory flow rate, you can see that there actually is no change in ventilation with increasing CO2. And that's the beauty of this measure, is it really focuses more on what's exactly going on. TIT tote, again, not a measure of ventilatory control. We would not expect to change. So it turns out that the hypercapnic ventilatory response, that is a ventilatory response to CO2, can be exacerbated if one is also hypoxic. So this is a normal arterial PO2 of 100. If we do this in someone with a PO2 of 70, then you can see that this curve is steeper. It's an increased ventilatory response. So hypoxia and hypercapnia are synergistic to increase ventilation. Similarly, acidosis and alkalosis, if one is alkalotic, it's going to depress the curve. If one is acidotic, it's going to make the curve steeper or the response more brisk. If you're awake or asleep, that also makes a difference. When you're asleep, your ventilatory response is depressed compared to wakefulness. For central chemoreceptors, minute ventilation increases linearly with increasing PCO2. Hypoxia and acidosis will augment the ventilatory response to CO2. Hyperoxia and alkalosis will inhibit the ventilatory response to CO2. Sleep and central nervous system depressants will inhibit the ventilatory response to CO2. Sushata Sritipayawan was a pulmonary fellow in 1999 to 2002 here at Children's Hospital. She did a study which pointed out that we need to think about the menstrual cycle in women, Progesterone is a respiratory stimulant. So the luteal phase past ovulation until the menstrual period begins is a time when in women normally ventilation is increased because of progesterone. So if you want to control for the menstrual cycle in women, you need to think about doing ventilatory response testing during presumably or preferably the follicular stage when you don't have this extra progesterone. And in fact, she did this in a lady with congenital central hypoventilation syndrome who was pregnant. Now, pregnancy is associated with increased progesterone, so one might think that you would have increased ventilation. But remember, in CCHS, there is no ventilatory response to CO2. So in this case, the red indicates her ventilatory response to CO2, which really didn't change with CO2 in the red, and when she was not pregnant. And when she was pregnant, you can see ventilation is generally decreased. This is presumably due to the increased load uh, placed on the respiratory system by the enlarging uterus. But certainly progesterone did not stimulate ventilation in this patient. Chronic CO2 retention causes the kidneys to retain bicarbonate. Therefore, the CSF bicarb increases to compensate for the elevated hydrogen ion concentration due to CO2 retention. And so central chemoreceptors adapt and reset, becoming less sensitive to the elevated PCO2. Thus, chronic hypercapnia depresses the hypercapnic ventilatory response. So Jimmy Payton and Soumya Swaminathan were both postdoctoral fellows in pediatric pulmonology from 1987 to 88, and they measured central chemoreceptor function, and were using their work to explain how to do this. So minute ventilation increases linearly with increasing P alveolar CO2. So we need to measure alveolar CO2 and minute ventilation. In the rebreathing technique, the P inspiratory CO2 increases by CO2 production, that is metabolic rate, independent of minute ventilation. So we also need to prevent a simultaneous hypoxic ventilatory drive because and further, the response will vary depending on how fast PiCO2 increases. The way this test is done, modeled after the original description by David Reed from Australia, is you start in a rebreathing system with 70 mLs per kilogram of 5% CO2, 95% oxygen. And then you basically allow the subject to rebreathe in that setting. Because you started with 95% oxygen, the inspired oxygen will never fall to low levels where it might stimulate a hypoxic response. And CO2 will increase according to metabolic rate, independent of ventilation. So it's a steady increase at rest. This is a picture of a system that we had. She's breathing here through mouthpiece. Here's the rebreathing bag here. This would be a normal ventilatory response to PCO2. Minute ventilation increases linearly and fairly tightly with PCO2. So as mentioned, minute ventilation increases linearly with alveolar CO2. In the rebreathing technique, the inspired gas is 70 mLs per kilogram of 95% oxygen, 5% CO2. The FiO2 of 95% prevents hypoxic ventilatory response. One could also measure step changes in minute ventilation in response to 5, 10, or 15% increased FiCO2. How can we separate central drive from pulmonary mechanics? Lung disease may decrease minute ventilation or VTTI. So during inspiration, the body does not recognize airway occlusion until 0.2 seconds. P.1 or P100 method measures the mouth pressure generated after 0.1 seconds or 100 milliseconds. This test is thought to be independent of lung disease. However, it will be affected by hyperinflation. Remember that if someone is hyperinflated, their diaphragm is at a mechanical disadvantage, and the same respiratory drive will result in a decreased diaphragm contraction. So P.1, P100 really never caught on. It's not something that people generally tend to use, and it does not completely correct for lung mechanics. Okay, let's look at peripheral chemoreceptors. So peripheral chemoreceptors are anatomically distinct from central chemoreceptors. They are located in the carotid bodies, which are at the bifurcation of the internal and external carotid arteries outside the brainstem. So they respond primarily to low oxygen, but also to large increases in PCO2 and large decreases in pH, and they stimulate the ventilatory controller directly, which increases minute ventilation. So as mentioned, they're located in the carotid bodies. A decreased arterial PO2 and decreased saturation cause an increase in ventilation. Increased arterial O2, all right, increased. And the values where this happens are not easy to find, but some references suggest a PO2 of around 160 torr. Decreased ventilation, so there's a hyperoxic depression. Large increases in PCO2 increase ventilation, and large decreases in pH increase ventilation. So this is the normal hypoxic ventilatory response. If we measure VE against saturation, this is an exponential curve. And note that nothing much happens until you get down to a PO2 of around 60. And then there's all of a sudden an exponential increase. Mother Nature was kind to those of us who like to do research in this area, and it turns out that the ventilatory response is linear with respect to saturation. So as saturation falls, saturation hemoglobin, minute ventilation increases linearly with respect to saturation. At sea level, peripheral chemoreceptors are not responsible for breathing minute to minute. They only stimulate breathing when the PaO2 is less than 60. So they primarily provide a backup when central chemoreceptors fail. So this is a fail-safe system to get you breathing again once your oxygen falls if central chemoreceptors are failing. This is the curve plotted for PO2 against minute ventilation, and this would be the normal curve. The red would be an increased ventilatory response. The blue would be a decreased ventilatory response. If we plot against saturation, decreased saturation down here, then normal is here. It's a straight line. The red is an increased ventilatory response hypoxia, and the blue is a decreased ventilatory response hypoxia. It turns out that the hypoxic ventilatory response is also synergistic with the hypercapnic ventilatory response. So if one has acidosis or hypercapnia, these are synergistic and will cause an increased ventilatory response hypoxia. If one is alkalotic or has a decreased PCO2, then this will depress the ventilatory response and have a more shallow slope. Doctors Payton and Swaminathan, again, looked at measurements of the hypoxic ventilatory response. Peripheral chemoreceptor, minute ventilation increases linearly with decreasing saturation. So we need to measure both saturation and minute ventilation. In the rebreathing technique, the fraction of inspired oxygen decreases by oxygen consumption. That is by metabolic rate, and it's independent of the ventilatory pattern. We need to prevent simultaneous hypercapnic ventilatory drive, and also the response will vary depending on how fast FiO2 decreases. So for this, again, off the method of Rebuck and Campbell, we have a rebreathing system. We're this time going to start with 130 mLs per kilogram of 14% oxygen and 7% CO2. The reason that we start with 14% is that if you start with 21%, it takes about 5 to 7 minutes before saturation begins to fall at all. So just to kind of shortcut this study so it's not so long, we start with 17%, which is about the time that saturation begins to fall. We have a variable flow pump and a CO2 absorber, so we can direct how much of the air goes through the CO2 absorber to keep CO2 constant. And then we're measuring minute ventilation, and of course, in this case, we had a mass spectrometer, but we could use pulse oximetry. This is a normal peripheral chemoreceptor response, or a normal ventilatory response to hypoxia. As saturation falls, minute ventilation increases linearly, again with a very robust R value. VE increases linearly with decreasing saturation. Rebreathing techniques, again, inspired gas, 130 mLs, FiO2 14%, FiCO2 7%. The reason here is we want mixed venous values, so we want to start with that. We start with the FiO2 of 14% because if you start with 21%, it takes about 5 minutes to get to where VE increases. And we start with an FiCO2 of 7% because we want to perform the test at the mixed venous fraction of CO2 value. David Gozal, who was a pulmonary fellow from 1990 to 1993, he looked at two other measures, or a couple of other measures of peripheral receptor function. One was a hyperoxic depression of ventilation. So minute ventilation decreases with increasing PO2. So subjects breathe room air for 3 minutes for baseline, and then 100% oxygen for 3 minutes. The minute ventilation in the last 2 minutes of the 3-minute hyperoxic challenge is compared to the average or lowest baseline minute ventilation. So this is done where subjects are randomized to breathe room air or 100% oxygen, and they are unaware of what they're breathing. And this is what happened, and we did this study with CCHS patients as well. So remember, CCHS patients did not have a ventilatory response to rebreathing hypoxia or hypercapnia. But the decrease in ventilation response to hyperoxia, and this is just two ways of quantitating this, was actually not significantly different between the two groups, suggesting the CCHS patients might have some peripheral chemoreceptor function. One can also measure acute hypoxic and hypercapnic ventilatory responses, and these are done in several ways. 5, tidal volume breaths of 100% nitrogen. 1, vital capacity inhalation of 5% CO2 and 95% oxygen. 15% CO2 and 85% oxygen, or 5% CO2 and 95% oxygen. Again, subject unaware, and this would be an example of that acute response. So here we're decreasing oxygen, 100% nitrogen here, and you can see that there is, following this, an increase in flow, an increase in tidal volume. Saturation obviously goes down, and so we can basically plot the saturation against each breath. There was, it turns out, a difference in response to acute hypoxia, primarily in respiratory rate, between controls and CCHS, but total minute ventilation was not significantly different between the two groups. Then for the CO2 tests, again, subjects are randomized and naive with respect to what they're breathing. This is, for example, the 15% CO2 in oxygen, all right? And you can see that this CO2 causes a brisk response in flow and tidal volume, which can be plotted against the untitled CO2 here. And these are the values. Actually turned out in this case that there were differences between CCHS and controls, although interestingly, 5% CO2 in nitrogen, the CCHS patients actually had a brisker response than the controls. Hypoxic ventilatory responses, interestingly, are decreased in people with the following: born and or grew up at high altitude, people with mountain sickness, people with cyanotic congenital heart disease, and some athletes, particularly successful distance runners. We'll talk about that when we talk about exercise. It's less labile than hypercapnic responses, so it's less affected by acid-base or pulmonary mechanical alterations, narcotics, or hypoxic CNS depressants. It's not affected by a decreased CO2 response. Basically, control of breathing, then, we can look at central chemoreceptors responsible for your breathing minute to minute, or peripheral chemoreceptors. Both are active and have their role. In addition, we have some pulmonary reflexes. So there are lung stretch receptors, also known as slowly adapting receptors. So stretch receptors inhibit inspiration with increasing lung volume. So they adapt slowly and steadily to inspiration, increasing the intensity of neuronal firing. This is also called the Herring-Breuer reflex, and there's efferent information sent via the vagus nerve. Rapidly adapting receptors, also called irritant receptors, are stimulated by chemical or mechanical stimulation of irritant receptors in airway mucosa in large airways. There's an initial burst of neuronal activity in response to inspiration, but this is not sustained. So it constricts the airways and promotes rapid shallow breathing, limiting penetration of whatever is causing this stimulation, and it contributes to initiation of periodic sighs, which occur in periodic breathing. Now, one thing is that this reflex actually matures at about 34 to 36 weeks of age. Prior to that, it causes apnea. So think, if we've got a preterm infant sitting here and all of a sudden that baby stops breathing, maybe what has happened is that some mucus or some minor thing has stimulated irritant receptors, which immature before 34 weeks actually cause apnea. It's something you can't see from the outside, but it definitely can be something that causes this phenomenon to occur. C fiber endings, or J receptors, they're stimulated by mechanical distortion of connective tissue structures such as pulmonary edema. Stimulation causes expiratory apnea followed by rapid shallow breathing. Stimulation can also cause increased mucus secretion and bronchial constriction. So quite some time ago when we talked about worker breathing, we said that people adopt the ventilatory pattern associated with the lowest worker breathing, and that people with stiff lungs or pulmonary edema have a rapid shallow breathing pattern. This might be a mechanism that causes that rapid shallow breathing. Their chest wall stretch receptors. Intercostal muscles are rich in muscle spindles, and muscle spindles, you recall, if they get stretched, they send back through reflex arcs messages to basically stop whatever you're doing to stretch it. These can help coordinate breathing during change in posture and during speech. There is a thing called the intercostal phrenic inhibitory reflex. Intercostal muscles are rich in muscle spindles. Inward distortion of the rib cage, as occurs in REM sleep in infants, is associated with early breath termination. So this reflex stops inhalation, decreasing inward rib cage distortion rather than inhalation of fresh air. And it can be cause of apnea or periodic breathing during REM sleep in infants. And this just shows work from my mentor, Charlie Bryan and Dick Nill, that show inspiratory time versus ribcage distortion. The more ribcage distortion, the shorter the breath. There are also a number of cortical influences that affect breathing. Cortical stimulation of breathing occurs with fever, pain, alertness, fear. To some extent, cortical depression of breathing occurs with the opposite of these. Now, we've seen a lot of things that can control breathing. Breathing is pretty important, so it's important that there be redundancy in critical control systems. This was illustrated on May 25, 1979, when a DC-10 airliner crashed after takeoff at Chicago's O'Hare Airport. Turned out a detached engine severed hydraulics controlling the rudder. There was apparently no redundancy in control of the rudder, and 271 people died. So this tragedy happened in part because of an absence of redundancy of critical controls. Breathing is too important to have only one control system. So we've talked about central chemoreceptors, peripheral chemoreceptors, lung receptors, chest wall receptors, cortical influences on breathing, voluntary breathing, and a few more. So breathing is important. So let's summarize what we learned today. There's both voluntary and metabolic control of breathing. Central chemoreceptors respond to small changes in PCO2, and minute ventilation increases linearly with alveolar CO2. Peripheral chemoreceptors respond to hypoxia and large changes in PCO2 or pH. Minute ventilation increases exponentially with decreasing arterial PO2, and it increases linearly with decreasing oxygen saturation. Breathing is too important to have only one control system. So we've just discussed central chemoreceptors, peripheral chemoreceptors, lung receptors, chest wall receptors, cortical influences, voluntary breathing, and there's a few more to come. So next time we will talk about control of breathing, part 2. Thank you again to our director producer, Katie Lewinter, and thank you again for joining me for the great adventure, pediatric pulmonary physiology.